Obstructive lung disease. Asthma. Introduction. Asthma is an obstructive lung disease characterized by a hyperreactivity of the airways that causes reversible obstruction and chronic inflammation. Allergic asthma. It is the most common type of asthma. It begins with intermittent symptoms in childhood and is usually associated with atopy and a good response to treatment. Age of onset. Allergic asthma typically presents in childhood. Non-allergic asthma typically presents in individuals older than 40 years. Note: childhood asthma affects boys more than girls. The incidence in females begins to rise at puberty, and by early adulthood, the prevalence is about equal. By age 40, more women than men have asthma. Risk factors for asthma include family history of asthma, past history of allergies, atopic dermatitis, low socioeconomic status. A number of prenatal and perinatal factors have been implicated in the development of childhood asthma. Example: maternal age, smoking, diet, and medication use. Asthma is due to interaction of multiple susceptibility genes with environmental factors. Susceptibility locus for asthma. 1. It's located on chromosome 5q. Gene cluster encoding the cytokines interleukin 3, interleukin 4, interleukin 5, interleukin 9, and interleukin 13 and interleukin 4 receptor. 2. Strongest and most consistent associations with asthma or allergic disease is associated with interleukin 13 gene polymorphism. HLA class II alleles are associated with production of IgE antibodies against some antigens, example, ragweed pollen. Polymorphism in ADAM33 gene induces increased smooth muscle and fibroblast proliferation. Alpha-2 adrenergic receptor influencing airway reactivity. Interleukin 4 receptors are associated with atopy, elevated total serum IgE, and asthma. Types of asthma. Asthma is of two major forms. 1. Atopic or allergic asthma, also known as extrinsic asthma. Atopic asthma, hypersensitivity, is the most common form. It commonly occurs in childhood and is in response to typical environmental allergens. Presence of family history of atopy. It represents a classic form of type 1 hypersensitivity. Increased serum IgE level. Examples are occupational asthma, allergic asthma, and allergic bronchopulmonary aspergillosis. 2. Non-atopic asthma, intrinsic asthma. It is seen in adults. Typically presents without a family history. It can be triggered by respiratory tract infections, chemical irritants, or drugs. Most commonly, NSAIDs. NSAIDs can cause drug-induced asthma by inhibiting the COX pathway. This leaves the unopposed Pathogenesis pathway that produces leukotrienes, which are potent bronchoconstrictors. Note: aspirin-exacerbated respiratory disease refers to the combination of asthma, chronic rhinosinusitis with nasal polyps. These features are also known as Samter's triad. Pathogenesis, acute phase reaction. Initial allergen exposure is followed by elaboration of specific IgE antibodies. After allergen-specific IgE antibodies are synthesized and secreted by plasma cells, they bind to high-affinity receptors on mast cells and basophils. When an allergen is subsequently inhaled and comes into contact with mucosal mast cells, it cross-links allergen-specific IgE antibodies on the mast cell surface, causing rapid degranulation and release of inflammatory mediators, which is a calcium-dependent process. This is known as the early or acute phase reaction. These mediators directly contract airway smooth muscle and may also stimulate reflex neural pathways. Late phase reaction. This early phase reaction is sometimes followed by a late phase recurrence of bronchoconstriction several hours later. The late phase response coincides with an influx of inflammatory cells, including innate immune cells such as monocytes, dendritic cells, and neutrophils. and cells associated with adaptive immunity, such as T lymphocytes, eosinophils, and basophils. The mediators released by these cells also cause airway smooth muscle contraction that is largely reversible by beta-agonist administration. Roles of various cells in pathogenesis of asthma. Eosinophils. The eosinophil is the most characteristic cell that accumulates in asthma and allergic inflammation. Its presence is often related to disease severity. Activated eosinophils produce lipid mediators, such as leukotrienes and platelet activating factor that mediate smooth muscle contraction. Toxic granule products, e.g. major basic protein, eosinophil-derived neurotoxin, eosinophil peroxidase, or eosinophil cationic protein that can damage airway epithelium and nerves. And cytokines, such as granulocyte macrophage colony stimulating factor, transforming growth factors alpha and beta, and interleukins that may be involved in airway remodeling and fibrosis. Eosinophils are recruited or activated by the hematopoietin interleukin-5 by the eotaxin family of chemokines via the eosinophil selective chemokine receptor CCR3 and by toll-like receptors. Mast cells. Mast cells are increased in number in asthmatic airways and may be found in close association with airway smooth muscle cells. In addition to producing bronchoconstricting mediators such as histamine, certain prostaglandins, and leukotrienes, mast cells also store and release tumor necrosis factor alpha, which is important in the recruitment and activation of inflammatory cells and in altered function and growth of airway smooth muscles. T helper 2 lymphocytes. The T cell population infiltrating the asthmatic airway is characterized by the T helper 2 subset of lymphocytes that produces a restricted panel of cytokines, including interleukin and granulocyte macrophage colony stimulating factor, but not interferon gamma when stimulated with antigen. The actions of the following cytokines produced by T helper 2 lymphocytes strongly suggest that they play critical roles in asthma and allergic responses. IL-3 is a survival factor for eosinophils and basophils. IL-4 helps in the differentiation of uncommitted T cells into Th2 cells, switch of B lymphocyte immunoglobulin synthesis to IgE production, and selective endothelial cell expression of vascular cell adhesion molecule 1 that mediates eosinophil, basophil, and T cell-specific recruitment. IL-5 is a major hematopoietic cytokine regulating eosinophil production and survival. IL-13 appears to contribute to airway eosinophilia, mucus gland hyperplasia, airway fibrosis, and remodeling. GM-CSF is also a survival factor for eosinophils. Basophils. While T helper 2 lymphocytes are a major source of the cytokines thought to participate in asthma, the basophil, in addition to producing histamine and leukotrienes, is a potent producer of interleukin-4 and interleukin-13, exceeding levels produced by T cells. Pathology. Histologically, asthma is characterized by various forms of airway remodeling, smooth muscle hypertrophy, and hyperplasia. Submucosal gland hypertrophy causes mucus plugging. Collagen deposition causes basement membrane fibrosis, thickening, as a result of increased vascularity. Eosinophils are most commonly seen in inflammatory infiltrates. Microscopic examination of mucus may reveal Kirschmann spirals, which are coiled mucinous spirals comprised of shed epithelium, often found in the sputum of asthmatics. Eosinophilic, needle-like Charcot-Leyden crystals may also be present in sputum or bronchial secretions of patients with asthma. These crystals are derived from the protein galectin-10, which is normally found within the primary granules of eosinophils. Crayola bodies, aggregate of desquamated epithelial cells. Patients relate a history of difficulty breathing, often with exposure to an allergen such as pollen, dust mite, cat dander, or mold, that reverses the removal of the offending agent or bronchodilator therapy. Note: Increased serum levels and lung expression of YKL-40 are correlated with disease severity, airway remodeling, and decreased pulmonary function. Clinical manifestations. Clinical manifestations of asthma include episodic expiratory wheezing. Inspiratory wheezing is observed when the condition is severe. Intermittent dyspnea, and chronic cough. Asthma also results in the following abnormalities on physical exam. A decreased inspiration and expiration time ratio is caused by a prolonged expiration due to obstruction. Increased anterior-posterior diameter caused by air trapping and an increase in respiratory volume. Pulsus paradoxus is defined as a drop in blood pressure more than 10 millimeters of mercury during inspiration. Hyperresonance on lung percussion. Prolonged expiratory phase on auscultation. Diagnosis. Asthma can be diagnosed in patients greater than 5 years of age and by demonstration of reversible bronchial obstruction using pulmonary function test, first line. If initial pulmonary function tests are inconclusive, second-line bronchial provocation test can be used. Pulmonary function test. A reversible airway obstruction measured by spirometry is essential to the diagnosis of asthma. This is demonstrated by reduced FEV1 by FVC ratio, that is, obstructive pattern, at baseline. A normal FEV1 in a patient who is symptomatic at the time of testing makes a diagnosis of asthma less likely. FEV1 increase more than 12% after bronchodilator administration. Reduced peak expiratory flow rate, PEFR, during asthma exacerbations. Single breath diffusion capacity is normal, or increased diffusion capacity of carbon monoxide, DLCO. Diffusing capacity in various obstructive diseases. Bronchitis shows reduced airflow and no change in DLCO. Bronchiolitis and emphysema both shows reduced airflow and reduced DLCO. Asthma shows reduced airflow and an increased DLCO. Bronchial provocation test. FEV1 reduction more than 20% with methacholine challenge test or histamine. FEV1 reduction more than 15% with exercise, hyperventilation, or inhaled mannitol. Methacholine is a bronchoconstrictor that can be used to measure the irritability of the airways. Patients with a drop of more than 20% in FEV1 following administration of methacholine are said to have reactive airways. CBC can show eosinophilia. Chest X-ray is usually normal but may show hyperinflation. Asthma exacerbation. Acute asthma exacerbations are episodes of worsening asthma symptoms and lung function. They can be the presenting manifestation of asthma or occur in patients with a known asthma diagnosis in response to a trigger such as viral upper respiratory infection, allergen or irritant exposure, lack of adherence to controller medication, or an unknown stimulus. Pharmacologic agents that can precipitate an acute asthma exacerbation include NSAIDs, beta blockers, cholinomimetics. Acute asthma exacerbations can be complicated by severe hypoxemia, hypercapnia, respiratory acidosis requiring intubation and ICU management. The treatment for an acute asthma exacerbation includes supplemental oxygen to maintain SpO2 more than or equal to 90%, inhaled albuterol, beta-2 agonists to increase airway diameter, systemic corticosteroids, decrease airway inflammation. Severe exacerbations may require inhaled ipratropium bromide, intravenous magnesium sulfate. Exacerbations that are refractory to treatment with impending respiratory failure require intubation and ICU management. Long-term management is focused on achieving and maintaining control over symptoms, maintaining normal activity levels, and preventing exacerbations. Intermittent asthma. Intermittent asthma is defined as having symptoms not more than 2 days a week, not more than 2 nighttime awakenings per month, Use of a short-acting beta-agonist not more than 2 days a week. No interference with normal activity. FEV1 more than 80% predicted. Intermittent asthma is managed with quick-acting inhaled beta-2 agonist, taken as needed to relieve symptoms. Mild persistent asthma. Mild persistent asthma is defined as having symptoms for more than 2 days a week but not daily, 3 to 4 nighttime awakenings per month, use of a short-acting beta-agonist more than 2 days a week but not daily, minor interference with normal activity, FEV1 more than 80% predicted. Mild persistent asthma is managed with daily low-dose inhaled glucocorticoids, as well as quick-acting inhaled beta-2 agonists taken as needed for relief of symptoms. Moderate persistent asthma. Moderate persistent asthma is defined as having symptoms daily, nighttime awakenings more than once a week, but not nightly, daily use of a short-acting beta-agonist, some interference with normal activity, FEV1 more than 60% but less than 80% predicted, reduced FEV1 FVC by less than 5%. Moderate persistent asthma is managed with low or medium doses of an inhaled glucocorticoid, long-acting inhaled beta-2 agonist, symptomatically quick-acting inhaled beta-2 agonist. Severe persistent asthma. Severe persistent asthma is defined as having symptoms throughout the day, nighttime awakenings up to 7 times a week, use of a short-acting beta-agonist several times a day, significant interference with normal activity, FEV1 less than 60% predicted. Severe persistent asthma is managed with medium or high doses of an inhaled glucocorticoids, long-acting inhaled beta-2 agonist, as needed, quick-acting inhaled beta-2 agonist. Aspirin-exacerbated respiratory disease. Agents used to treat aspirin-exacerbated respiratory disease include: first line, leukotriene receptor antagonist, montelukast, zafirlukast. Second line, 5-lipoxygenase inhibitor. Xyleutin. Xyleutin is considered a second-line agent in part due to a risk of hepatotoxicity. Commonly used medications in asthma. Short-acting beta-2 agonist, SABA. Example: inhaled albuterol, oral terbutaline. Mechanism of action: dilation of bronchial smooth muscles. Treatment of choice in the management of acute asthma exacerbations, also used as reliever medication during maintenance treatment. Note: frequent administration of an inhaled short-acting beta-2 agonist, SABA, is the treatment of choice to reverse airway obstruction caused by bronchospasm. Long-acting beta-2 agonist. Example: salmeterol, formoterol. Used in long-term maintenance treatment. Inhaled corticosteroids, ICS. Examples: budesonide, fluticasone, mometasone. Others: beclomethasone, cyclesonide, triamcinolone. Mechanism of action: inhibit transcription factors. Nuclear factor kappa B leads to decreased expression of pro-inflammatory genes. Used as long-term maintenance treatment. Note: inhaled corticosteroids do not take full effect until they have been used for approximately 1 week. Leukotriene receptor antagonist, LTRAs. Examples: montelukast, zafirlukast. Mechanism of action: prevent leukotrienes from binding to their receptors and causes decreased bronchoconstriction and inflammation. Used as long-term maintenance treatment, particularly in children. Consider for exercise-induced asthma and aspirin-induced asthma. Muscarinic antagonist. Long-acting muscarinic antagonist, LAMA. Tiotropium bromide. Short-acting muscarinic antagonist, SAMA. Ipratropium bromide. Mechanism of action: competitively inhibit postgangliotic muscarinic receptors in bronchial smooth muscle and leads to bronchodilation. Long-acting muscarinic antagonist, option for long-term maintenance treatment. Short-acting muscarinic antagonist, in combination with short-acting beta-2 agonist, used in the management of severe and life-threatening asthma exacerbations. Oral corticosteroids. Examples: methylprednisolone, prednisone. Mechanism is similar to inhaled corticosteroids, used in severe persistent asthma and in the management of acute asthma exacerbations. Additional medications used in the treatment of asthma. Biologics for severe asthma. Monoclonal antibodies. Omalizumab, anti-IgE antibody, binds to serum IgE and decreases expression of high-affinity IgE receptors on mast cells and basophils. Prevents binding of IgE to Fc epsilon Ri, reduces release of inflammatory mediators, reduced asthma symptoms and exacerbations, used in select cases of allergic asthma. Mepolizumab, reslizumab, benralizumab. Monoclonal antibodies against IL-5, block the effectors of IL-5 on eosinophils, reduce chemotaxis, reduce cell differentiation, maturation, and activation. Used in severe eosinophilic asthma. Methylxanthines. Theophylline. Inhibit phosphodiesterase, PDE, increased CAMP levels. Mast cell stabilizers. Chromones. Chromoline sodium. Prevents release of inflammatory mediators from mast cells. Preventative treatment prior to exercise, not commonly used. Leukotriene pathway modifiers. Xylotin. Inhibit 5-lipoxygenase, reduce production of leukotrienes from arachidonic acid, reduce bronchoconstriction and inflammation, used in exercise-induced asthma and aspirin-induced asthma. Note: theophylline is no longer routinely prescribed due to the risk of toxicity. It is used solely as an adjunctive or alternative therapy. The following drugs are not effective during an acute asthma attack: long-acting beta-2 agonist, leukotriene pathway modifiers, theophylline, mast cell stabilizers, biological agents. Image discussion. A section of lung from a patient who died in status asthmaticus reveals a bronchus containing a luminal mucus plug, submucosal gland hyperplasia, and smooth muscle hyperplasia. Higher magnification shows hyaline thickening of the subepithelial basement membrane and marked inflammation of the bronchiolar wall with numerous eosinophils. The mucosa exhibits an inflamed and metaplastic epithelium. The epithelium is focally denuded. Photomicrograph of lung tissue shows severe bronchial inflammation and obstruction of the lumen due to an accumulation of mucoid exudate. The epithelial basement membrane appears thickened, and the number of goblet cells has increased drastically. This is a typical appearance of bronchial asthma. Micrograph of a sputum sample shows dark spiral-shaped casts of mucus are visible. Kirschmann spirals are typically seen in the sputum samples of patients with bronchial asthma.